Before administering spinal anesthesia, it's vital to know when not to proceed.
When a long medical needle penetrates the outer skin, traverses multiple underlying tissue layers, and enters a fluid-filled cavity, it performs a neuroaxial blockade. This procedure is the purposeful disruption of the body's central nervous system boundaries to induce anesthesia. While the injection itself is localized, it triggers systemic changes across the entire body, primarily by altering systemic sympathetic tone. Because this intervention deliberately crosses major physiological boundaries, it carries severe risks if performed under the wrong conditions. Medical trainees often treat the list of conditions where a spinal block should be avoided as a simple checklist to be memorized. But relying on rote memorization fails when confronting complex clinical scenarios. Safe administration requires mapping the patient's mechanical and physiological thresholds before the needle ever touches the skin. To understand these absolute limits, we will deconstruct the top contraindications by tracing their direct mechanisms of catastrophic failure. Assessing risk requires anticipating exactly how an induced disruption will interact with the patient's pre-existing physiological vulnerabilities. This animated diagram shows a cross-section of the spinal canal. Notice the needle passing through the highly vascular epidural space, inducing immediate microtrauma to the surrounding tissue. This physical trauma requires perfectly intact hemostasis. The body must be able to clot efficiently to prevent continuous internal bleeding at the puncture site. Clinical guidelines set strict thresholds for coagulopathy, a platelet count falling below 75,000, or an abnormal PT-INR. These markers frequently manifest in patients with recent anticoagulant use or those suffering from preeclampsia-induced thrombocytopenia. When blood fails to clot, it pools and continuously expands within the tightly confined, rigid structure of the epidural space. This resulting pathology is known as a spinal hematoma. The expanding hematoma exerts immediate, unrelenting ischemic pressure directly on the spinal cord, causing permanent neurological damage. The second strict local contraindication involves the integrity of the puncture site itself, active infection. During the pre-procedure physical exam, any visible indicators of a local abscess, such as focal redness or severe swelling, must be identified. Puncturing through infected tissue actively drags bacterial pathogens from the skin surface directly into the otherwise sterile cerebrospinal fluid. Seeding bacteria into this space initiates a dangerous spinal epidural abscess. Similarly, patients presenting with generalized sepsis originating from other sites cannot receive a block. The procedure induces unpredictable, destabilizing shifts in systemic hemodynamics. The needle acts as a bridge, compromising local tissue integrity, either via uncoagulable blood or active bacteria, instantly turns a routine microtrauma into an unrecoverable central nervous system catastrophe. Zooming out from the puncture site, this fluid dynamics model maps the entire central nervous system as a single connected entity. Cerebrospinal fluid pressure operates as a continuous column, extending from the brain all the way down to the lower back. This structural reality leads to the third contraindication, elevated intracranial pressure, or ICP, and known brain lesions. Elevated ICP typically presents clinically as severe uncontrolled hypertension, altered levels of consciousness, mass lesions, or hydrocephalus. Under these conditions, a dural puncture creates a sudden, low-pressure vent at the very bottom of this continuous fluid column. The extreme pressure gradient forces high-pressure cranial tissue toward the new low-pressure zone in the spine. This mechanical displacement is called brain herniation, or coning, as the brainstem is physically forced through the narrow foramen magnum at the base of the skull. It becomes violently compressed. This acute compression drastically reduces cerebral blood flow, leading directly to rapid brain death. Because the neuroaxis is a closed pressure loop, ignoring intracranial dynamics allows a small puncture in the lower spine to mechanically destroy the brainstem. Shifting focus entirely onto the systemic vascular network, this dual-panel model illustrates the immediate cardiovascular effects of local anesthetics. When a spinal block is administered, the anesthetic shuts down the local sympathetic nervous chain. This effect is defined as a sympathectomy. Depriving the lower body of sympathetic tone causes massive, immediate systemic vasodilation, forcing blood pressure to plummet. This physiological reality dictates the fourth absolute contraindication: severe hypovolemia. This demographic includes patients experiencing acute trauma, major hemorrhage, or active hypovolemic shock. These patients manage to maintain their baseline blood pressure only through intense, compensatory sympathetic vasoconstriction. Applying a spinal block to a hypovolemic patient surgically removes their singular compensatory mechanism. Stripping away this baseline vasoconstriction without adequate fluid volume causes unrecoverable cardiovascular collapse. A spinal block removes the precise compensatory mechanism keeping a hemorrhaging patient alive. Looking at this clinical decision flowchart, we transition away from the physical sciences to the clinical and ethical realities of patient care. The fifth and final absolute contraindication is patient refusal. A patient explicitly rejecting the block creates a complete, unnegotiable hard stop for the procedure. It is the physician's mandate to educate the patient, clarify specific risks, and present alternative options, but any form of coercion is entirely unacceptable. Safe spinal anesthesia requires 4 distinct physiological pillars: the hematologic capacity to heal, normal intracranial pressure to maintain perfusion, sufficient systemic fluid volume to survive vasodilation, and an uninfected entry point. But all 4 of those physiological pillars are entirely reliant on the patient's autonomy to accept the risk of the procedure. Mastery of spinal anesthesia involves rigorously mapping the exact threshold where an intervention becomes an injury.